So I won't really talk much about what is long COVID. You'll be hearing a lot about that from other speakers. I'll talk a little bit about why long COVID is difficult to measure from a surveillance standpoint. And I'll talk a little bit about how the Washington Department of Health estimates the burden of long COVID in our state. This is actually done by a lot of people who are a lot smarter than me, who use terms like Latin hypercube sampling. I have no idea what that is. So if any of you have any technical questions about their techniques, I won't be able to answer them. But I do hope to give you a little bit of a flavor of how we generate these estimates. And then I'll talk a little bit about why a public health approach to long COVID, especially a public health approach that emphasizes the social drivers of health, is so important. So as Dr. Chu mentioned, long COVID is really an umbrella term that probably encompasses several different syndromes. And there are a number of reasons why long COVID is difficult to measure. Though acute COVID-19 infection is a notifiable condition, long COVID is not. So a notifiable condition is a disease that's required by law for healthcare providers and laboratories to report to their local health jurisdiction. So as we know, not everybody who gets COVID-19 tests or gets diagnosed with COVID-19. The impact of long COVID is quite variable. It's not like measles that has a very predictable set of symptoms. One person's experience with long COVID and their symptoms can be very different from another person's, and that makes it difficult to count and assess. Not everybody who develops long COVID seeks healthcare, and even amongst those who do see a healthcare provider, not everybody gets diagnosed with long COVID. And rates of long COVID vary quite a bit by severity. So we know that those who've been hospitalized for their acute COVID-19 infection have higher rates of long COVID than those who are not hospitalized. And we'll talk a little bit about how rates of long COVID vary by age, race and ethnicity, and geography. So all of our notifiable condition data goes into a database called WDRS, which stands for the Washington Disease Reporting System. And it's this database through which numbers are crunched to generate our dashboard. So we used to have a COVID-19 dashboard on the health department website, which has since been replaced by a respiratory illness dashboard. But we pull data from WDRS to populate this long COVID model that I'll talk about. And basically, we use what's called a compartmental model, which means that we consider all of the population as being part of one of several boxes. And we start off with considering the boxes of people who have COVID-19, that's a box on the lower left, as well as people hospitalized with COVID-19, that's the box here on the lower right. And we actually use the number of hospitalized cases to also give an estimate of the number of unreported symptomatic cases of COVID-19. From the scientific literature, we know the rates at which people who are not hospitalized go on to develop long COVID, and also rates at which people who are hospitalized go on to develop long COVID. And then similarly, we get estimates from the literature at the rates at which people with long COVID, whether they got from hospitalization or not, either recover or go into the unrecovered box. So imagine people flowing between these different boxes, and that we simulate those with a computer, and that's how we develop these numbers. And then we we run this model using several different layers, layers with age groups, eight age groups, 5 different race and ethnicity groups, 2 sexes, 3 status of vaccination, and 39 counties within our state. Now you can see that there's a lot of missing data in our Washington disease reporting database. Where for example, race and ethnicity, 42% of cases in WDRS have missing race and ethnicity data. So when we see this, we use the median value for a particular demographic for this model. So what does this model tell us? It tells us that long COVID does significantly impact the lives of many Washingtonians, and there are perhaps 107,000 Washingtonians who live with significant activity limitations from long COVID. And this is based from data that was updated in December 2023. We estimate that that adults in younger age groups, adults ages 18 to 59, have higher rates of long COVID than either children or older adults. And you might be puzzled by this, as I am. We had mentioned that rates of long COVID are higher in people who are hospitalized. We know that older adults have higher rates of hospitalization, so why don't they have higher rates of long COVID? Well, there are a lot of different theories. We don't really understand. We don't really know for sure. It's possible that that younger adults are more likely to survive their acute COVID infection and go on to develop long COVID. It's possible that adults in the younger age groups are less likely to be vaccinated than older adults. Possibly younger adults because they are working and in school more than older adults, practice less social distancing and maybe practice less social distancing for the intention of protecting themselves from infection. So it possibly could be a combination of factors that leads to this difference. We also estimate that females have a higher burden of long COVID than males, and other speakers may have more insight on this. I believe it's possibly due to differences in inflammatory response and the immune system response between women and men that account for this difference. Those identifying as Black and those identifying as Hispanic or Latino also have higher rates of long COVID. And we know that race does not have a genetic basis. And so often when we in public health see differences by race, we think of the social drivers of health and how they are influencing differences in disease rates. And I'll talk about that in a moment. We also see that the prevalence of long COVID is estimated to be higher in central and eastern Washington than in western Washington. And again, there are many potential reasons for this. So in this map, those counties with higher rates of long COVID are shaded in red, and those with lower rates of long COVID are shaded in blue. So we do know that these counties in central and eastern Washington have, on average, a younger population, so that could be part of it. We also know that these areas of the state have lower vaccination rates, so that could be part of it as well. And it could be that the social drivers of health, again, have a powerful influence. Before the pandemic, if we were to show a map of life expectancy or of chronic disease, the map would look pretty similar to this, actually, where poor health is experienced by many communities in central and eastern Washington. And there are a number of reasons why this might happen. Often we think of the social drivers of health as being very powerful influences on different rates of disease in populations. So education, access, and quality, we know that those who have higher education status are more likely to be vaccinated. Healthcare and quality, if you have more access to healthcare, you're more likely to be vaccinated and more likely to have access to antiviral treatment. Neighborhood and the built environments, if you live in a place that has grocery stores more handy and more opportunities, parks, bicycle paths for physical activity, you're more likely to have healthy eating and active living, which decreases your risk for chronic conditions and long COVID. Social and community context, we know that racism, stress, trauma increase one's risk of chronic conditions, and that could increase the risk for long COVID. And then economic stability. We all know that poverty impacts all of these, and that poverty comes with a higher risk of chronic conditions, and lower rates of vaccination, more difficulty accessing healthcare. So what this means is that the really important scientific advances in long COVID are so needed. But unless we really are mindful of the social determinants of health, the social drivers of health, it's possible that any new therapies that are developed for long COVID could exacerbate inequities rather than solve them. You can imagine if there was a treatment that was only accessible to those who were wealthy with privilege and not accessible to those with less privilege, how that could serve to exacerbate inequities in long COVID in our state. So just to recap, the burden of long COVID is high and appears long-lasting in Washington state. There's a lot of variation that exists by demographics and geography. This long COVID model that has been developed is very promising, but further refinement and validation is needed. And a public health approach that addresses the social drivers of health is really important if we're going to approach long COVID equitably. So that's the end of my slides. I just want to thank all of those at the Department of Health who work on the long COVID model, particularly Aaron Hamlet, who's one of our CDC epidemic intelligence officers who really spearheaded the modeling work on long COVID. And that's the end of my slides. I have some spare slides that we can come back to if needed. Otherwise, I'll hand things over to Dr. Chu, or hand things over to Dr. Chow to speak next. Thanks.